So this is the first of a series of webinars on current controversies in colorectal cancer that's been organised by the Educational Training Committee of ESSO. So my name is Henry Smith. I'm a colorectal surgeon from Copenhagen in Denmark, and I'll be moderating this session and providing a bit of an introduction on the topic before we have two presentations, one from Peter Tannis and one from Mads Klein, to go through some of the more interesting topics on early colorectal cancer. We're going to start with a brief introduction before I provide a bit of a background, and then Peter Tannis is going to talk about different strategies in terms of surveilling or operating on patients with early colorectal cancer, before Mads talks about some novel approaches to stratifying risk in these patients. And then we'll have time for some question and answers at the end. So if there's any questions that you have during the webinar, if you enter them into the chat function, then we'll hopefully have time to go through them at the end. So just to introduce ESSO and the webinar itself. So ESSO is the European Society of Surgical Oncology. It's more of a global society than a European society that has a focus on spreading the message of surgical oncology as an own specialty and the role of surgeons in the treatment of patients with cancer, and has the aims of improving surgical education on a global scale, and also trying to standardize the treatment of patients with different types of cancers, in providing different educational resources for surgeons and training. It's possible to join ESSO. If you've not heard of ESSO or not a member, you can either click on our website or click on that link there. There are a number of benefits to being an ESSO member. So there's a range of different other educational activities, so hands-on courses and theoretical courses that you can have reduced rates of registration for. There's also a discount on the ESSO's journal, the European Journal of Surgical Oncology. ESSO also provides a number of educational grants that can be applied for if you're a member, and also has exchange programs for visiting other institutions to broaden your experiences. ESSO also has its own research academy, which provides guidance for people who are in the first stages of starting research projects or want to expand their research projects to have a broader network. And it also is a way to network with a global society of surgical oncologists and like-minded surgeons across the globe. ESSO is also involved in the European exam for surgical oncology, which is held once a year at the ESSO Congress. And more information about that can be found both on the website and by scanning that link. And as I said, the ESSO and the British Association of Surgical Oncology are some joint owners of the European Journal of Surgical Oncology, which has an impact factor now of 2.9, with ESSO members and BASO members having discounts on open access publication fees with that journal. And so finally, ESSO is also has an annual conference next year. It's in Madrid in November, so it's a fantastic opportunity to share the work that any of you are doing and be inspired by the work that others are doing on a global scale. So that was the introduction for ESSO, and so now I'm going to kick off and give an introduction to the topic that we'll be discussing, and that's the current treatment and outcomes of patients who have early colorectal cancer. I don't have any conflicts of interest to declare. We'll start with the very basics. So what is early colorectal cancer? So these are, for the most part, people refer to T1 cancers as being early colorectal cancers. Some studies and some centers will also include patients with T2 cancers in that terminology. But these are basically superficial cancers that involve the most innermost layers of the bowel and can be removed with a variety of local excision techniques. They're an important group of patients because the incidence of early colorectal cancers is rising. This is undoubtedly due to the introduction of national screening programs across the globe. These are data from a recent Danish study that compared what proportion of patients are diagnosed with T1 and T2 cancers from a period from 2004 to 2008 to 2014 to 2019. And you can see that there's a clear increase in the amount of patients who are diagnosed with these early cancers. If we look just at T1 cancers, these have doubled in that period of time. And if we take T1 and T2 cancers together in patients with colon cancer, these account for over a third of patients. And in patients with rectal cancer, these account for over half the patients that are diagnosed with new rectal cancers. So this is a big group of patients, it's an expanding group of patients, and we really need to be sharp in terms of how we treat these patients and aware of what challenges diagnosing cancers in an earlier stage can bring. So what are those challenges? There are two main ways that people are diagnosed with early colorectal cancers. Sometimes we know what we're doing, so we have patients who have large polyps. That's probably more common in the rectum than colon cancers, where we've either taken a biopsy or have a suspicion from the endoscopic appearance of that polyp that it is a malignant polyp, and planned a local excision as part of a broader treatment strategy. But there are a considerable number of patients who are diagnosed unexpectedly. It's more common in patients with colon cancer, where a presumed benign polyp is removed and then is found to have a focus of cancer after pathological examination. But regardless of whether we expect it or not, the challenge is the same in both these groups of patients. There are some patients that have lymph node metastases, there's some patients that don't. Those patients that don't have lymph node metastases are theoretically already cured and don't need any more treatment and could be entered into surveillance programs or even not followed up at all. And those patients who have lymph node metastases need to have further surgery. And if we take a sort of an average, if we take T1 and T2 together, we could say approximately 20% of these patients will have lymph node metastases. So the majority of these patients will already be cured. But the problem is finding out who's who in this group of heterogeneous patients. If we didn't do anything to any of these patients and just followed them all up, then we would potentially undertreat 20% of those patients. And that's significant because there's a real jump in the stage of these patients according to whether they have lymph node metastases present or not. So if they have no lymph node metastases, they have a low risk T1, T2 tumor, then their risk of recurrence within 5 years is very, very low, approximately around about 7%. If they have lymph node metastases, then that's a real jump up to about a 25% recurrence risk within 5 years. But then there's also the indications for further treatment. So these patients would be eligible for adjuvant chemotherapy. And if we don't have lymph nodes to examine, we don't know which patients are which, and we don't know which patients we're under treating. On the other side, we know that completion surgery is not without risks. Complications happen after colorectal cancer surgery, probably in around about 20% of patients, probably a little more in patients with rectal cancer. It's not unheard of for patients to die of those complications, and we're becoming more and more aware of the longer-term impacts on bowel, bladder, and sexual function in patients, which occur in probably more than a third of patients. And one can say that these risks are acceptable if patients have residual disease, if they need to have further surgery to be cured of their cancer. In those patients who are already cured and don't have any residual disease, it's hard to say that they have benefited from having further surgery if they're exposed to these risks. So how do we decide what to do with these patients? Historically, international guidelines have been based on a range of different pathological risk factors. So these are factors that have been shown in many studies to be associated with the presence of lymph node metastases. And there are numerous international societies that have their own guidelines, but they're all fairly uniform. They include lymphovascular invasion, tumor differentiation, submucosal invasion, tumor budding, and resection margins. And generally speaking, all these guidelines are in agreement that if any of these factors are present, any single factor is present, then completion surgery would be recommended. So many of those guidelines say as well that if any of those factors aren't accessible or are missing, then they should be considered as present, which means that if you have a specimen where there's no risk factors but one's missing, then completion surgery could be justified. So how well does this system work? At present, these are data from another study from Denmark, but they'll be similar from many of the other series that have been published internationally. If we look first at patients with colon cancer, there's around about 60% of patients with early colon cancer undergo an initial local excision, and the majority of those are probably with unexpected diagnoses of cancer. After being discussed at MDTs, around 40% of those patients are selected for completion surgery, but only about 12% of those patients are found to have residual disease once their specimen's been examined. So there's over 85% of those patients who had already been cured by the local excision, and one could argue haven't benefited from having completion surgery. If we look at rectal cancer, local excision is more common, and again, it's probably more intended in that patient group where we have a more focus on avoiding the morbidity of rectal cancer resections. There's also a more selected group that proceeds to completion surgery, so only a quarter of those patients are selected for completion surgery. But even in a super selected group of patients with early rectal cancer, only just over 15% have lymph node metastases. So again, it's far, far more common for these patients to have no residual disease than to be found residual disease when they undergo surgery. And so that begs the question, I mean, that is over treatment any way that you look at it, and what level of over treatment is acceptable? And that's a very difficult question to answer because it depends on which angle you're looking at it. If you have a young, fit patient who has a low risk of operative complications, and then would have a long surveillance period or even a long period where they could be psychologically affected by the potential of having residual disease that's left and not treated, then you could say that a 1 in 5 chance of there being something left is fair enough, and those patients should be operated on. Whereas if you have an old, frail patient who has high risks of having a complication after surgery or dying after surgery, and also has other comorbidities that might mean that surveillance becomes less relevant in that population group, then there's a need to be much more precise in terms of what the benefits of the surgery are for that patient. Similarly, one can look at what tumor location means for that discussion. It's not to say that a right hemicolectomy isn't without risks, but it is associated with a different set of complications than an abdominal perineal resection with a permanent stoma. So these are factors that play a role for patients, and should definitely play a role for us when we're making decisions in terms of who to offer completion surgery. So we could say that the current stratification is inaccurate, but why so? If we have a range of different guidelines and they're all some broadly in agreement, why is it that we operate on so many patients that don't have residual disease? But the fact is that these factors don't really correlate particularly well with the presence of lymph node metastases in real life. And again, these are data from Danish studies. But if we look at all these different risk factors, so lymphatic invasion, venous invasion, tumor budding, if they're present in a specimen, then there's about a 20% risk of patients having lymph node metastases. So you're still far more likely not to have residual disease, even if you have risk factors for lymph node metastases. And the same is true when we look at sort of the cumulative effect of these risk factors. So in patients who don't have any risk factors in a specimen, they have about an 11% risk of having lymph node metastases, and they account for around 40% of patients who underwent completion surgery in that study. The risks are fairly similar between them that have no risk factors, 1 risk factor, or 2. It's all around sort of 10 to 15%. And this group of patients account for the overwhelming majority of patients who are offered completion surgery in this study. And the real increase in risk is only really seen in patients who have 2 or more risk factors, where that risk increases to over about a third of patients that will have lymph node metastases. But that group of patients only account for less than 5% of all patients who undergo completion surgery. So again, there can be arguments made that these risk factors that we use to allocate patients to treatment aren't particularly robust in clinical practice. A further issue is that those factors are often missing. So the majority of these factors are unassessable or have not been assessed in around 10 to 15% of patients. Submucosal invasion is missing in this study in almost half of patients, and there's lots of work that's been done that suggests that maybe that as an independent risk factor for lymph node metastases isn't particularly important anyway. But when we look at the broader picture of this in that cohort, over half of patients were missing a single risk factor. So according to some guidelines, over half of patients would be considered for completion surgery based on an incomplete or impossibility to complete a pathological assessment alone. So that's where we stand at the minute in terms of patients who have early colorectal cancers. You can say it's still very challenging to determine who needs further treatment and what that treatment should be in patients who've had a local excision of an early colorectal cancer. Histopathological risk factors have been the workhorse in terms of risk stratification, but they correlate poorly with the presence of lymph node metastases in real life clinical practice. And we can say that the current risk stratification we use, they're based on these risk factors, and we know that they're associated with significant rates of overtreatment in this patient group. So if we carry on doing what we're doing, we'll carry on operating on too many patients who have early colorectal cancer. So then the question we beg is how can we do better? So the first one would be sort of, can we teach old dogs new tricks? So can we alter stratification based on those factors that we have now? Or could we look for something completely different? Do we need better methods of risk stratification that are different to those that we have now that could be more accurate in determining who has residual disease and who would benefit from further surgery. And so they coincidentally feed nicely into the two talks that we're going to be having now. So I'm going to stop sharing my screen there, and I'm going to invite Professor Peter Tannis to give his presentation. He is a colorectal surgeon at Erasmus in the Netherlands and in Rotterdam, and a professor at Erasmus and the University of Amsterdam. He's been involved in development of guidelines in the Dutch Colorectal Cancer Group for many years, and he's been the PI of several multi-center studies and large population studies. He's also the co-investigator of the Crossroads study, which is based on completion surgery after locally resected early colon cancer. So I assume we'll be hearing a bit more about that. Peter, over to you.
Thank you for the introduction. Do you see my slides?
Not yet, Peter.
Let's see. Can you see it now?
Yeah, there we are. Yeah.
So thanks for inviting me to present this. I put it in presentation mode. So I would like to discuss the role of watchful waiting in the setting of mainly the early colon cancer. So I will not talk too much about the early rectal cancers this night. I've no disclosures. And I also want to mention Leon Moons. He's a gastroenterologist from Utrecht here in the Netherlands, and we work very close together on all the projects in the Netherlands for early colon cancer. It's also good to know that in the Netherlands, the gastroenterologists do the local excisions of early lesions. So there is no surgeon involved in endoscopic local excisions. And that's why we very closely cooperate together, the surgeons and gastroenterologists. And Leon is also the chairman of the T1 CSC working group, which is a very active scientific group in the Netherlands. This has already been mentioned. So the conventional way of dealing with this type of early lesions is that we excise them when we have risk factors, or when it's a T2, we advise completion segmental colectomy. I've put here 15% risk. Henry said 20% is a little bit how you look at the literature, but this indeed means that you overtreat the majority of patients. And the morbidity and mortality has also been mentioned. The picture is a little bit different for rectum and colon. But if we look at the ratio between the potential oncological benefit on one hand and the morbidity and mortality of these type of surgeries, then we see really a paradigm shift in the Netherlands for the last few years, in which we see that we are de-escalating on completion surgery for these lesions, and that there is an increasing role for active surveillance. And if a recurrence is detected during this surveillance, then people are treated with salvage surgery if possible. So if it's still salvageable recurrence, then people are undergoing the surgery at a later time. But this will, of course, result in much less overtreatment. So what are actually the goals for completion surgery? And we can divide in the local regional control and also distant control. Of course, we prevent local regional control with surgery. So we can try to avoid the outgrowth of lymph node metastases and also local recurrences in the abdominal wall, especially if it was an incomplete resection. There is also a risk of bowel wall recurrence. And there is also the idea that probably if we leave the lymph node metastases, then these might give rise to distant metastases. So we also assume actually that if we are performing completion surgery, that we also might reduce the risk of distant recurrences. But I've put a question mark, as you can see on this slide, because the question is whether this is really the case. And that's actually based on a sort of Hallstadian principle that we think that lymph node metastasis can give rise to distant metastases. But in fact, we know that some patients will develop distant metastases in the absence of lymph node metastases. And the other way around, if we perform completion surgery, those patients can still develop distant metastases. And if we look in the literature, then we see that patients with distant metastases of early colon cancer originally had zero disease. So this is an important finding, that probably the distant metastases originate from the primary tumor themselves and directly, and these tumor cells enter into the bloodstream and develop as distant recurrence with only probably a very small role for lymph node metastases. And also the local regional recurrences, if you look at the percentages in the literature in patients who have been treated with watchful waiting, this percentage is lower than the percentage that you expect based on the percentage of lymph node metastases that you can find in completion surgery specimens. And this has nicely been reviewed by one of the PhD fellows in Leiden. This is the thesis of this PhD student, and in chapter 10 he has written a nice systematic review of the literature, looking at the series in literature where they did surveillance of the T1 high-risk lesions. And then you see that, for example, the local regional recurrence, any local regional recurrence was only 5%. And we know from the series, as we just said, that we expect like 15 to 20% of lymph node metastases in those specimens. So then the question is, are those lymph node metastases all growing into a local regional recurrence? And it might be the case that the immune system will already eradicate some of those tumor cells in the lymph nodes. So probably it's not that high percentage of important lymph node recurrences. If we look a little bit more in detail to these two strategies, so if we perform completion surgery, so we almost eliminate the risk of local regional recurrence, but we still have distant recurrences, and those can be treated curative or palliative. And this will result in a certain cancer-specific survival rate. If you look at intensive surveillance, then we of course expect more local regional recurrences because we leave the mesocolic nodes. Also have a certain percentage of distant metastases, and the local regional recurrence and distant metastases might also be treated curatively. So it's not always that if you have a recurrence that this will lead to death. So there is a certain percentage that we can salvage, and this appears to be in the literature even as high as 70%. So this also results in a certain cancer-specific survival, and our hypothesis is now that we expect that this might not be that different, actually, the cancer-specific survival rate in the end. And that's based on several studies that looked at completion surgery versus surveillance. And the first 4 studies also did propensity matching and to correct for confounding, because if you look at the literature, most people treated with surveillance have a higher overall risk. So these people are more elderly or have more comorbidities. So you expect higher higher mortality and lower survival in this patient group. But if you correct for these confounders, then you see that there are actually no differences in overall survival, disease-free survival, or distant metastasis-free survival. But this indicates that probably our completion surgery does not really affect the oncological outcome in the end. And from a patient perspective, this is actually the picture. If you perform completion surgery, then you have a risk of mortality. You might be cured by completion surgery, but you also can get recurrent disease despite completion surgery. Those are the distant metastases. And of course, there are competing non-cancer related risks, which increases with increasing age. On the other hand, if you do watchful waiting, you can also be cured by salvage surgery, probably in a much higher proportion than we expect. You probably have a little bit higher risk of recurrent disease that can't be cured, but also in this patient group, there are competing risks. And then the question is, are patients accepting the risk of cancer recurrence? So there have been also quality of life studies performed by the group of Leiden, and they showed actually that this was not the case. So if you perform surgery or just endoscopic treatment, then the quality of life and the fear of cancer recurrence were comparable. So this also supports from a patient perspective that we might safely shift to a more conservative strategy. So in other words, there should be a substantial oncological risk to justify completion colonic resection, given the fact that the majority of distant metastases still occur despite surgery. Salvage surgery for mesocolic or interluminal recurrence can be curatively treated in approximately 60 to 70%. There is a postoperative mortality of about 2%, major postoperative complication rate 10 to 15%, and the life expectancy is also determined by other diseases, age, clinical condition. We also looked at our data, and it's interesting to see that even in the period from 2014 to 2017, there was already a shift towards more surveillance, even in high-risk patients. So the orange groups with the orange circle around it are surveillance for high-risk lesions. And on the left hand, those are the screen detected, on the right hand, the non-screen detected. And it's interesting to see that indeed the distant recurrences are not much higher, actually almost comparable than in the group with completion surgery. Of course, we see more local recurrences, but that's expected, and those are actually not very, very high. So these are also in the range of like 2 to 3%. And this was all the basis for revising our guideline, in which we said probably we should go away from that much high rates of completion surgery. This has been published on the 18th of March, and this will be prospectively validated in the Crossroads project. So it's already online, but it's in Dutch, so probably difficult for most people to read. And what we first did is that we used a new stratification for the risk of lymph node metastases, because we want to have a sort of gradual increase in surveillance. And based on studies, we saw that 15% risk of lymph node metastasis is probably a good cutoff, and below we can then probably safely implement the surveillance strategy. In the 15 to 25% risk of lymph node metastases, we have to do shared decision making with the patient, whether he or she wants completion surgery or watchful waiting, and above 25%, it's probably still better to do surgery. These are the groups. It's a very busy slide, but we have defined, based on several prediction models, the 4 groups. So the groups with a very low risk, less than 5% of lymph node metastases, the 5 to 15%, 15 to 25, and higher than 25. And that's based on the morphology, so pedunculated or non-pedunculated polyps, the T1 or T2, and the number of risk factors, and whether it was resected completely. So using this table, you can see in which group your patient is located. And the Crossroads study will now prospectively validate that we are implementing active follow-up for the 5 to 15% risk of lymph node metastases. And then we have 5 years of follow-up and also sending questionnaires to these patients. And in the Crossroads 2, we are performing shared decision-making for the 15 to 25% risk group. And then our hypothesis, as I already said, is that we expect a similar cancer-specific survival with a margin of 3% non-inferiority margin. And then we need 500 patients. And this is our active follow-up schedule that we will use in the Crossroads. This is also included in the Dutch guideline. So if we are following patients with T1 high-risk lesion, we use this follow-up schedule. So in conclusion, following guideline change, active surveillance will be the new Dutch standard for locally excised PT1 to T colon cancer with an estimated risk of lymph node metastasis of 5 to 15%. And this will be prospectively validated in Crossroads 1 study. And for the a little bit higher risk, from 15 to 25%, we use shared decision-making for patients. And for the higher risk patients, more than 25% of lymph node metastases, we still perform completion surgery. So this is my talk.
Thanks, Peter. That was great. It's always inspiring to see what a different approach is to taking these patients on and really pushing the boundaries in terms of what's acceptable for both them and for us. So it'll be really interesting to see what the results of those studies are now they're ready. We'll keep all the questions to the end, so we'll go on now to the last presenter, Mads Klein, who's another colorectal cancer surgeon from Denmark. He works in a different center than I do. Mads has been part of the Danish Colorectal Cancer Group for many years. He's been actually involved in them, but he's also been the force behind the Improve PT1 project, which has been looking at circulating tumor DNA as a different mode to stratify patients with early colorectal cancer. So I'm imagining we'll hear a bit more about that in a few moments' time. Mads?
Thank you so much. Thank you for the invitation. I'm going to share my slides, and I hope you can hear me. Let me see if I can get this to work. Yeah, I'm going to tell you some details about this study that has not been published yet, but it's a spin-off study, you may say, to a series of nationwide studies on circulating tumor DNA in colorectal cancer. And this study focuses on exactly what we're discussing tonight, the problem with the PT1 patients. As Henry so great talked us through, we are seeing an increasing number of early stage colorectal cancers or polyp cancers, especially after we in Denmark implemented screening in 2014. And of course, they are often removed by endoscopy or local resection. And again, my numbers are also around 15 to 20% of these small tumors may have lymph node metastasis, and based on the histopathological characteristics, as both Henry and Peter told us, we decide whether we should perform a completion resection or not. And again, 80 to 85% of patients are overtreated with that completion resection. So inspired by the ongoing circulating tumor DNA studies, we asked ourselves, can we more accurately identify patients with residual disease after polypectomy using circulating tumor DNA? So that was this project was about. We started out with a pilot study recruiting patients from all the 10 centers in Denmark participating in the IMPROVE studies, patients that had polypectomy or other type of local tumor resection, and the pathology assessment said it was a T1 tumor. Then the patient was planned for a completion resection based on the criteria we have, that is the risk factors being present. And prior to that completion resection, we did blood samples in order to perform the analysis that I will get back to later. And after the completion resection, we got a new pathology assessment, of course, telling us if there is residual disease or if there were residual disease left in the patient or not. And we managed to find 14 patients with residual disease and a lot of controls. Our primary endpoint of the study is the number of patients, or the fraction of patients that we could correctly stratify using ctDNA into the two groups, those without residual disease and those with residual disease. In other words, those who need further treatment and those who did not. In this setting, we have to use an extremely sensitive method for analyzing the presence of circulating tumor DNA, because we may be in a setting where it's just one positive lymph node. So our collaborators in Aarhus at the molecular department, they have another group of collaborators in New York at Memorial Sloan Kettering, and they published earlier this year an article of a new whole genome sequencing method, where we are able to, if we have some tumor DNA, and we have that from the polypectomies, and some normal DNA from the patient, we are able to perform what's called deep whole genome sequencing, and thereby identify a lot of mutations from the tumor. We're actually able to identify at least 10,000 tumor-specific mutations for each tumor. And as a surgeon, I like the expression, the tumor fingerprint, then I understand what we're looking for. So we can extract these data and identify this specific tumor profile or fingerprint. And then when we do the subsequent blood sample again sequence the cell-free DNA in that blood sample, we're able to look for that fingerprint with an extremely high sensitivity and a low error rate using this novel method. Actually, the method has been proven to be sensitive enough so that if there's only 1 in a million parts tumor DNA in the sample, what's called the tumor fraction, we should be able to detect it. Great. We have divided our analysis or our project into 2 phases, because many of the tumors are removed by polypectomy are quite small. Then we have very limited sample size, or the limited samples of tumor cells. Then we had to be completely sure that we are able to perform the analysis correctly. So to be sure of that, we have started with 10 patients that we know have stage 3 disease, and we had some stores or samples stored from them to see if our method is working. And then we will proceed to phase 2 with our cases to see if our results, if we can stratify the patients correctly. And we have completed phase 1, and the 10 stage 3 patients, you can see here that we are able to detect at least 14,000 mutations from each tumor. That is the fingerprint that I talked about for each tumor. And using that fingerprint, we are able to detect with a higher level of sensitivity if there is tumor DNA in the blood sample. These two graphs just show that we have tested for background noise to see if there is a signal, if we look for the same mutations in other patients. As you can see, there is a good separation. And if we perform another analysis where we use both DNA strands to make the variant call, as we call it, we reduce the noise and improve the signal even more. So now we know that the method is working, and this is when I would have loved to show you the results. They are so close. I had a meeting just the other night with our PhD student who's in New York at the moment, performing the analysis at Memorial Sloan Kettering, asking her, can I just share results from just one patient? But they are, as you can see, in progress, and in just a few weeks we will have our first results. So we're very eager to see if we are able to identify the patients with residual disease using this method. And the plan is, if that is successful, as we believe and hope, is to progress to a randomized clinical trial and to allocate patients to completion resection either through this ctDNA assessment or through our current method, using only the histopathological parameters for risk assessment. And we hope in the future to save a lot of colons and also rectums, and maybe even the owners of these colons and rectums. I have to mention all the collaborators that worked with us in this study, both from Aarhus University, Department of Molecular Medicine, all the surgical pathological departments or pathology departments in Denmark, and also our collaborators in New York. So that was my talk. I hope all the molecular stuff made sense. I've been learning a lot as a surgeon myself. Thank you so much.
Thanks, Mads. That was great. I think it's I think we're as excited as you are to see what the results of that study will be. I think there's really great potential to see that should provide a more robust way to say who are the bad actors and who aren't. So it'll be fantastic to see the results from that study at the end. I think we'll open up to some of the questions now. There've been a couple of questions in the chat, so I'll just see if I can find who came for the first of those. There've been some people who've been asking about the follow-up program, Peter, in the Crossroads study, but there's also been some people who've been asking if the slides can be shared afterwards. So I think that would be something that can maybe be taken later. But if you could just pop the follow-up program up from your presentation again, just so that people could have a chance to see how often these patients are being there. Yeah.
This is a follow-up schedule indeed. So it's yearly CT and CEA, and then also inspection of the scar, almost yearly, with colonoscopies for the first and fourth year after the local excision. And then as part of the Crossroads study, we also sending patient's questionnaires as displayed here after 1 and 3 years.
And so is there anything, so there's always the thing that comes up in MDT discussions about these patients as well, when margins are close but not clear, that they need to be followed up in terms of their luminal recurrence as well. Does that factor into the crossroads?
Yeah, so it a little bit depends. That's the other slide. I can also share this one again, probably. So here in the Dutch guideline, there should be for several of the lesions belonging to the risk category, there should be an R0 resection or an R1 resection. And the R1 resections are now defined in the Netherlands as it's within 0.1 millimeter. So it was not the 1 millimeter margin that we used in the past, but we are now more liberal and say that even if there is, for example, a 0.2 millimeter margin, then it's considered R0 resection. Perfect.
So there's also a question from the ESSO president, so I suppose we should probably take before the others. So that's how long do you expect the accrual to take, Peter, for the Crossroads study, and how long follow-up would you like to have? And when can we have an answer? I think are the most pressing factor.
Yeah, so that's a good question. So this project has been financed by a governmental with a governmental grant, and this is quite nice that we got 7 years time to perform this project. So we expect an accrual rate of 2 years for the 500 patients in Crossroads 1, and we will continue accruing Crossroads 2 through the whole study period, because we expect that about 60 to 70% of all the patients will belong to Crossroads 1. Those are the vast majority of patients. So the more high-risk patients is also a minority of the patients. That's also the reason why we powered the study on the Crossroads 1 subgroup with 5 to 15% lymph node metastases. And then we have a 5-year follow-up. So we continue with follow-up after 5 years from the last included patient. Yeah, that's also, I saw in the chat that we will expect also to find the late recurrences. Yeah, there might be also recurrences after 5 years, but this will be very small, I guess.
And there's also a question that is there a protocolized way of managing regrowths, or is that going to be based on?
Yeah, so within this project, we have also working groups who work on, for example, the radiology during follow-up. So there are several radiologists involved in the Netherlands in this project, and they have a working group in which they share also the cases of recurrences, and we also now retrospectively identify cases of local regional recurrence, how this will look at a CT scan from a large cohort that the T1 CSE working group already collected in the past years. We're collecting all these CT scans and see if we can also learn the radiologist how to look at a CT scan when you perform active surveillance of an early colon cancer. Because I think we should learn to look at those CT scans and find them early on, and how these recurrences appear. I think we can learn a lot from this. And then also we have the more therapeutic working group who look at is this still a salvageable recurrence or a non-salvageable recurrence? So we are also planning to have sort of panel discussions when we have recurrences in this study to present it to the panel and then see what people think. Of course, if it's just a mesocolic node that's a little bit growing on the CT scan, you can just do a segmental colonic resection, but you might also imagine that it's more advanced or growing into surrounding structures. So you might also think of induction chemotherapy, or and the same holds true for the distant metastases. Is it still something that you can do a liver resection or ablation or radiate lung lesions. So we will have a sort of panel to look at all the recurrences.
That sounds really good, Peter. Again, it'd be really interesting to see what the outcomes of that is, because it's something that isn't really done in a standardized fashion at all.
No.
So there's another one.
Can I ask Peter just one short question? Are you planning some interim analysis as well, perhaps with after 2 years of follow-up, where most of the recurrences may have happened, so that we can, as a community, learn even faster from your experiences?
Yeah, the problem is that the number of events is expected to be so low. So I think it's very difficult. So we have no planned interim analyses. And that's also the reason that we actually said we already implement this in the Netherlands and include it in the guideline. It's actually a very strange decision, because this is not how evidence-based medicine works. So often you do a study, and if you find your evidence, then you change the guideline. But here we were actually so convinced about what we already saw as a circumstantial evidence in the literature, with all the hypotheses being validated in studies that we could find, that we said as a guideline committee that it's probably not fair to do so much surgery with so much morbidity and mortality if you have not really a clue what you are doing. So we introduced this actually historical, just also on a hypothesis. So we have been starting doing completion surgery just on a hypothesis. It's not that this was evidence-based. So you can put the discussion in two ways. So is it fair to do some historical treatment, not evidence-based, or change it to conservative management, which is also still not evidence-based, but then do a prospective project? So this was the discussion which we had in the guideline committee. So actually we think it's safe, are not performing an interim analysis, but I think a lot of countries worldwide think this is too progressive. So I think a lot of countries will wait for the results after 7 years.
Yeah, I think it's probably a fair comment there, Peter. I think we're all waiting in excited expectation to see how it goes. I had a question for you, Mads, about is there an idea of what the cost is? So now if you're using a very sort of intensive sequencing method for the circulating tumor DNA, is it too early to say what the real world cost would be if it came into clinical practice, or is there any idea about how that would play into using that for all these patients?
That's completely right. It's much too expensive at this moment for broad clinical use. I don't know the exact prices, but because it's a collaboration with the clinic over there, and also because it's the newest and most sensitive analysis, it is still too expensive. But we wanted, as a proof of concept, to use the most sensitive method that we have at the moment to see, does this work? Are we able to identify maybe even a lymph node metastasis of just a few millimeters, or some residual cancer in other places? So yeah, it's not ready for clinical use now, but as a proof of concept, we hope it can inspire others to make these analysis, and then it will of course bring the price down.
And you said there was there wasn't a huge amount of tissue samples that you had available for some of these patients. Is there enough, if you were to look at a more off-the-shelf, cheaper version of, if you saw that the very, very sensitive method worked, is there a possibility to compare it with a cheaper method, or is it?
You can do that. Yeah, our collaborators in Aarhus have developed what they call a TriMeth assay, where it's much cheaper. It's not whole genome sequencing; it's just ddPCR method that's much more readily available and even off the shelf in many places. So if the concept works, then of course you're able to test less sensitive methods, and if they can give us the same result, or even with a slightly less good sensitivity, that may also be acceptable. As Peter says, we are operating too many patients. Then maybe if we find 8 out of 10 cancers this way, then we can spare the remaining 85 patients that do not have any residual disease.
Perfect. Very much in agreement, Matt. I think we see if there's any other questions that we haven't covered. There was one question, Peter, in terms of how you classify your 3 risk groups into the green, orange, and red. At which criteria are they based on? You need to just turn your microphone on.
That's the slide I tried to share previously, so I can try to do this once more. So these are the criteria for the several groups, and yeah, it would take several hours to explain how we came to these categories, but it's based on several prediction models. So we had, as I said, a huge database from the T1 CSC working group from the past, in which we could use several modelings to calculate these risks, and also used several models published in literature. So this is actually a combination of several prediction models, and then we came up with these categories.
Perfect. I think we've covered all the questions that had come in the chat, and I think we've also run out of time a bit now. So I think we'd just like to end by thanking you both for taking the time to come and present to your work. It's been great to have an insight into the things that you're doing, and there's high expectations that they'll really help move on the field in this group of patients. And thanks to everyone who's been in and joined in this webinar. As I said at the beginning, this is the first in a series of webinars that are coming from ESSO. So there'll be another webinar, the date to be confirmed shortly, on organ preservation and neoadjuvant treatment in these patients. And then we hope in the new year to have another seminar on acute presentations of colorectal cancer to follow up on this. But for now, that's everything. Thank you all for being here, and have a very good evening.